Thank you so much for the invitation. It's a pleasure. I wish I could be there. I would much rather be giving this in person, but we'll do the best with our technology. I'll talk about physical activity and cancer prevention. So great. So I have nothing to disclose. I think I'm sure all of you are aware of the general recommendations for physical activity. This is for the general population. These are US recommendations, but I think they're very similar in Korea. We recommend 150 to 300 minutes per week of moderate intensity physical activity, or 75 to 150 minutes per week of vigorous activity, or a combination of both. So these are the general recommendations. I think when most people think of recommendations for physical activity, they think about cardiovascular disease, diabetes, maybe a little bit about cancer, but not so much. But we'll see that maybe cancer should be considered more importantly. There are recommendations for cancer. The World Cancer Research Fund and the American Institute of Cancer Research make recommendations for physical activity, specifically for cancer. And these recommendations are a few years old, so I think they need to be updated. But the WCRF, their recommendations are for colon, postmenopausal breast cancer, and endometrial cancer. So physical activity is beneficial for those cancers. And then the American College of Sports Medicine came up with actually more cancers. So they actually thought physical activity was important for 7 cancers, including breast, colon, endometrial, but also the esophagus, kidney, bladder, and stomach. I'll explain this slide a little bit because this study came out 2016. So now it's actually not that recent. It's 7 years old. And the importance of this study was that it was a pooled study of 12 large cohort studies. So this is like, really a lot of the data of the world based on large studies. You can see that they had almost 1.5 million adults in these studies. So these studies assess physical activity, mostly self-reported, and then follow individuals for cancer. And you can see they looked at 26 cancer types. Now, the way the results are shown here, these are hazard ratios, or you can think of relative risks. So, for example, for lung cancer, we see 0.74. So that means the more active individuals had a 26% lower risk of lung cancer. So all of the cancers on this side are protection, null, as you can see, like they're on a relative risk of about 1. And surprisingly, there are actually 2 that were in a positive direction, where physical activity was associated with a higher risk. So just to, I'll talk more about this, but just to summarize briefly, leisure time physical activity was inversely associated for 17 cancer types, possibly harmful for 2 cancer types. So it's obviously important to exclude any harm. We don't want to tell people to be physically active if they're going to increase their risk of cancer. But I think there's a clear explanation for both of these. These are prostate and melanoma. And so the prostate cancer, there was a small increase, a 5% increase in risk. But this is likely due to higher detection rates from PSA screening. People who are physically active tend to be more health conscious, and they go to the doctor more often, and then get PSA screened, especially in the United States. So you over-detect prostate cancer. So we think that this is just an over-detection. Now, for melanoma, there was a 27% increased risk. We don't think that this is causal. We don't think physical activity increases risk of melanoma. It's just that people who are more physically active are in the sun more. This does tell us that people who are physically active getting sun, that's good, a good thing, but they may want to consider sunscreen, particularly if they're light-skinned. So that could be a harmful effect, but we wouldn't recommend people not to be physically active, just to be more careful about sun exposure. What's more important are that leisure time physical activity was inversely associated or protective for 17 cancer types. Let's look at these more closely. All of the cancers associated with leisure time physical activity are the ones associated either with tobacco use or obesity, and these are the two biggest risk factors for cancer. So this I made this slide. The paper we're talking about was published 2016. I reviewed this paper and other aspects of physical activity in 2018. So, but what I noticed is that there are 17 cancers where physical activity is associated inversely with, and they're all either obesity related or tobacco related. So the yellow ones are the ones that are tobacco related. And by tobacco related, tobacco was a strong risk factor. So smoking, caused at least about half the cancers or more. So obviously people know about lung cancer. So it would be obviously good for people not to be smoking, but it would be interesting if physical activity protected against cancers associated with smoking. And this is a summary, a meta-analysis. These are different studies that looked at physical activity in lung cancer. And you can see the summary relative risk was 0.83. So the more physically active people had a 17% lower risk of lung cancer. Now, the question is whether this is a causal association. We don't care so much about associations that are not causal. We want physical activity to really protect against lung cancer. But for lung cancer, it's a bit complicated because we know smoking, this arrow means smoking is a direct cause of lung cancer. We also know that smoking may reduce physical activity, or people who smoke may be less active. And also smoking causes lung disease and loss of lean body mass. So people who smoke a lot may be less active. Now, if that's true, then physical activity may appear to be a risk factor, but it's not really a risk factor in a causal sense. It's just because physically active people smoke more, and it's the smoking that really causes the lung cancer. And that actually is what is actually indicated, because this study looked, this is again a meta-analysis. So these are summary relative risks. So when they look at so for recreational physical activity, when they look at the whole population, they see a 14% significant reduction. However, when they stratify by smoking, so among the never smokers, there's no association, it's 0.99, which is not significant. So amongst non-smokers, physical activity is not protective. So we think that's pretty strong indication that it's actually the smoking that's causing the increased risk, and physical activity is not a causal risk factor. That point is summarized here. So for cancers that are strongly associated with smoking, it's unclear if the protective association with leisure time physical activity is causal until there's more definitive evidence. At least I will assume that the association is non-causal, and that those who suffer from the effects of smoking, such as lung damage, may be less likely to exercise. So it's not a causal association. So I'm not going to say much more about smoking. It's still debatable, and some people may argue that it could be a causal association. But I'm going to focus more, I think, which is on this remarkable finding that essentially all of the cancers that showed up in that pooled analysis to be associated with physical activity are also considered obesity-related cancers. By obesity-related cancers, these are the cancers that many organizations assume that there is a causal association between obesity and the cancers. So this is a list of 13 cancers, and these are certified as causal by the many organizations such as IARC, that's the International Association for Cancer Research, and then the W World Cancer Research Fund, and Surgeon Generals. These are all causal associations where you can see that these are relative risks summary from meta-analysis. So many studies. So each one of these is based on like 50 studies. So it's these are hundreds of studies that show obesity. And there are other indications, looking at biomarkers that indicate that they are causal associations. So excluding the smoking-related cancers, which we already talked about, the cancers associated with physical inactivity are also mostly associated with obesity. So there's this really correspondence between the cancers where, if obesity is a risk factor, physical activity is going to be protective. Obesity has been a consistent risk factor for many cancers. The magnitude of the association varies. So like for esophageal and endometrial cancer, obesity is a very, very big risk factor. For the others, it's less. Obesity is one of the factors. It's not the only factor, but they all add up. 13 cancers are actually quite important from a public health perspective. Let's think about this a little bit. So if we think of obesity as adiposity, so physical activity may have two effects on cancer. One, there may be a direct effect. So it may have something unrelated to adiposity. It has nothing to do with obesity. But we know physical activity also reduces body fat. So there could be at least two types of mechanisms. One is where physical activity is beneficial because it reduces adiposity, and the other is because it has other effects on cancer. So this is the same study, the Moore study that showed all the cancers associated with physical activity, protective association. These are the hazards ratios or relative risks that are not adjusted for BMI. And so, like, for example, let's look at esophageal adenocarcinoma. Physical activity was associated with a 42% lower risk of cancers of the esophagus. Now, when they adjusted statistically for BMI, body mass index, it was a 38% reduction. So it got a little bit weaker, but it's still there. So most of the effect appeared to be from physical activity and not the BMI. So, and the contrast and example is endometrial cancer, which there was a 21% reduction in risk being physically active, but this essentially went away. It was only a 2% non-significant reduction when you adjust it for BMI. So this doesn't say that physical activity is not important for endometrial cancer. It just says that the effect of physical activity is largely mediated through BMI. So for example, for esophagus, it's 10%, 90% is directly related to BMI, to physical activity. And for endometrial, physical activity is probably acting largely by reducing adiposity. Most of them are like 70% range, 75, 76, 70. This is kind of a simplifying slide. If we think of it this way, it's physical activity affecting body weight, and then that's being protective for cancer, or other effects of physical activity. Based on the studies that I showed, we'd say roughly, and these are approximate, 2/3 of the effects for most of the cancers, except for endometrial cancer, is the effect directly on cancer, and then 1/3 is by reducing adiposity. So this is essentially what I just said. However, we should look at visceral adiposity, which may be more insightful than just body mass index. I think many are aware that body mass index is a useful but not a perfect indicator of adiposity. And we'll see why this is particularly important for physical activity. So these are two scans, CT scans done at the navel, the umbilicus. So you can look at visceral fat, and the fat shows up white. So this is more fat. This is more like muscle. So as many people know, there are two large components of fat. One is visceral, around the organs, the viscera, and then there's subcutaneous fat. So what's interesting is here, these are two individuals with the same body percent fat, age, sex, and BMI. The BMI is 24. But you can see that there's 3 to 4-fold higher level of visceral fat in this person. And this is also for the same waist. So in other words, you can have two people with the same body mass index, even the same waist, but you can have big differences, 3 to 4-fold differences in visceral fat. And it's particularly important for Asian populations, such as in Korea, where there's a tendency for people that people have lower BMI in general, so their body weight's lower, but they have a tendency to accumulate visceral fat. So this is a similar slide. I put this here sort of for fun because these are 8 different men with the same circumference, and you can kind of see a big difference in almost an 8 to 9-fold difference in visceral fat. That's an incredible difference. And so I had a little quiz here. I look at A and B. One of these is likely to be an athlete, and one of them is a couch potato. And if I was there, I can see you can raise your hands if you think which was more likely to be the athlete and the couch potato. But the main point here is that even with the same body mass index and waist circumference, you can have a big difference in visceral fat. So those are nice pictures, but I wanted to show some actual data. So this is from a meta-analysis. Now each point here is from a study. So each point is from an intervention study. So these are actual interventions, not just observational data. And so the black is studies of caloric restriction, and the open circles are from exercise. So these are various studies, like some may have been 3 months or 6 months, different interventions. But the point here is, so let's focus on the physical activity, the open circles, is that this is the weight change they had in the study, percent weight change. And this is the percent change in visceral fat. So for example, you can look at this study. This is one of the extreme studies where in the intervention, they only had about a 2% weight drop, and they had about a 40 to 45% reduction in visceral fat, dramatic reduction in visceral fat. So you can kind of see the slope here. Like overall, there's a 5% weight change corresponds to about a 20 to 25% reduction in visceral fat. But there's some studies that show, these are probably the studies that people were more compliant. So you can actually show like some studies where people had, less than a 10% weight reduction, but a big reduction in visceral fat. Now, I just wanted to show one study might make the point a little easier. So this is a representative study, but remember, this is based on many, many studies. So in this study, this was a 12-week exercise, and it was like 5 days a week for 50 or 60 minutes. These are people that were largely obese. So this is 3 months, not that long. The BMI dropped 3%, hardly dropped, 33 versus to 32 units, hardly a drop. But the visceral fat, which they measured directly, dropped 22%. And then they looked at insulin resistance, and that dropped 35%. So physical activity had a big impact on insulin resistance, which is probably important for cancer, but hardly a drop on body weight. So that's important to keep in mind. So this summarizes that. So moderate levels of physical activity, such as a daily hour brisk walk, may not have a large effect on body mass index, but it will have a substantial effects on visceral and also hepatic. The visceral fat's also strongly associated with liver fat, which also may be important for cancer. And various lines of data are compatible with the effect of physical activity on many cancers is largely mediated through a reduction of visceral and hepatic adiposity, and subsequently on insulin and inflammation. This is a conceptual slide, and I'll go through this because I think it has some important points. And this really, I think, for me, summarizes obesity, physical activity, and cancer. I've been studying this for about 30 years, and I think that this slide summarizes almost everything that I learned, which is kind of sad. But anyway, so let's think of the yellow here is the body's, like the adipose tissue, and roughly 90%, it varies, but 90% is subcutaneous fat. so the fat under the skin, and only 10% is the visceral and the liver fat. So this is a small component. But interestingly, this is the component that's really sensitive to physical activity and also diet, which I won't talk about today, but there's a lot of similar arguments we can make for diet. And I showed you previously, remember just the previous slides where physical activity had a big reduction in visceral fat, but didn't really change overall body fat that much. What's interesting is that the visceral and hepatic adipose is the primary determinant of things like inflammation and insulin resistance. And I think this is what's important for various cancers, particularly the digestive system cancers, which I'll talk about a little more. Now, remember, endometrial cancer, you had to have a reduction in body weight to have the effect of physical activity. So physical activity was only beneficial if it was enough to lower body weight. And the reason is likely that endometrial cancer is not associated with visceral fat. There's other evidence for that. It's the overall fat which produces estrogen in postmenopausal women that's associated with endometrial cancer. So this slide really kind of summarizes the effects physical activity on visceral and hepatic adiposity and the mechanisms that affect mainly digestive system cancers, and then estrogen, which is also important, but it's related to endometrial cancer. Okay, so now for the last part of my talk, I think I hopefully convinced you, if you weren't already convinced, that physical activity does causally lower risk of some cancers. Broad question, I think physical activity is definitely important for cancer. So the remaining questions are largely details, and these are important details, so I put that in quotes. So like how much, what type of activity, when in the life course, how much of a benefit. And then mostly what I talked about is aerobic exercise. There's also weight training that's been less studied. So these are the important practical questions. And I'm just going to show a little data from the 3 studies that I work mainly with, and Dr. Dong-Hoon has also done a lot of these studies. So these are the Harvard cohorts, Nurses' Health Studies 1, 2, and Health Professional Studies. And I think that the reason these studies are important, and I'll show, is that they have repeated measures of physical activity every 2 years over a 40-year period. Most studies, epidemiologic studies, have 1 or 2 at most measures of physical activity, but we measured every 2 years over a 40-year period. So we get really person's lifelong physical activity. We have validated physical activity and lots of other data. These are very large studies. I won't have time for much of the details. This is one of the recent questionnaires. These are the different questionnaires we ask, basic activities, most common in the US. And we've been now asking about intensity, and we have weight training questions. So I don't have time to spend on the questionnaire, but I think why these cohorts offer unique data that supports much of what I said, but gives some information on those and like some of the details. So it provides a better dose response for independent effects of vigorous and moderate physical activity. Important question is, do you have to do vigorous activity, or is moderate enough? And it limits reverse causation and tells us when in the life course physical activity is beneficial. So I'll just show some data. Now, some of this is a little bit technical, but I'll try to explain this. This is a study Dr. Dong-Hoon Lee did. This illustrates an important thing. This is a dose response. This is looking at mortality, total mortality, and this is physical activity met hours per week, so going up. And then we did the analysis in 3 different ways. You get 3 different types of dose responses. The first way, we just used one questionnaire, the baseline questionnaire. We didn't update the data. And it does show a reduction with more physical activity, but then actually the risk starts going up. And sometimes people describe this U-shaped association. If you have too much activity, it may be bad. But when we use repeated measures, you see a very different dose response where you get the benefit or the reduction in all-cause mortality, but then it levels off. So maybe getting once you reach this point, doing more won't help you, but it won't hurt you. So I think that's important. So it shows you a difference in whether you use only one questionnaire like most studies do, or you have repeated measures. And then the other thing is, so you get a better dose response if you have repeated measures. This is another analysis done by Dong Hoon that looked at vigorous activity and moderate activity. This is the reference group are people that do neither. They don't do much vigorous or much. And then these are categories of moderate physical activity. So you actually see pretty high levels, 300 to 559 minutes per week. And what you kind of see here is that you can do either moderate or vigorous, and at some level, you max out the benefit. So for example, if you look at people who do very little moderate activity, they do mostly vigorous. And the vigorous is here. So this is going up in vigorous. So this is 300 minutes per week of vigorous. So there's a 40% reduction. So if you do very little moderate, you can get up to a 40% reduction if you do a lot of vigorous. And likewise, in this case, if you're doing 300 to 599 minutes of moderate, so you do a lot of moderate acts, you walk like 2 hours a day, you can do vigorous activity. It doesn't hurt, but it doesn't help you. So you kind of max out the benefits. So this addresses the question, again, for all-cause mortality, is you need to do, you can do both, or you can do a combination, but you don't have to do vigorous. You can get the benefit by doing a lot of moderate activity. Or if you don't have time to do moderate, to walk, you could just do more vigorous activity. So now getting back to cancer, I mentioned that a lot of the benefits for cancers were on the digestive system. And this is not our data, but this is from a meta-analysis from 47 studies. And you can see all throughout the GI tract, you see reductions, or at least associations, where high versus low physical activity shows a reduction. But this doesn't inform on the dose response. So we actually looked at this, again, using the repeated measures. This is a study done by, led by Nana Kuhn in 2016. And these are for the whole digestive system. So all of these cancers combined. So a lot of cancers. And what you can see here is the dose response. So up to a degree, more is better. And the maximum benefit was at about 30 met hours per week. So that's about, roughly, if you do it all in walking, about 450 minutes of walking, or running 225 minutes a week, which is actually, a bit more than the recommendations. These are the minimum recommendations, which would be like, let's say 150 minutes of moderate activity. You do get a lot of benefit, but you actually get more until you reach about 450 minutes a week of walking, or running 225 minutes a week. Now, timing throughout the life course, I'll just focus on this one. So this is colorectal adenoma, which is a precursor for colon cancer. So this is kind of like studying colorectal cancer at an earlier stage. And in this study, so the reference group is the low physical activity in adolescence and low physical activity in adulthood. So relative to these people, you get a big benefit if you're highly active in adolescence and in adulthood. You have about a 40% lower risk. But you do also get some reduction if you're high in adolescence and low in adulthood. So it does show that you do get, at least for colorectal cancer, you do get some benefit for being active in adolescence, which is nice to know. But if you maintain the activity, you get even a bigger reduction. But this helps inform on the life course, like when is physical activity important. It's important both early and late for colon cancer. Now, for pancreatic cancer, it's kind of interesting that in that study that I showed, it was actually one of the cancers, that did not have a significant reduction. It suggests a 5%, but not a significant reduction in risk. Now, what's kind of interesting is that we've done some studies led by Chen Yuan that looked at pancreatic cancer, and actually show really strong, these are other risk factors like obesity and smoking, not for necessarily for physical activity, but risk factors for pancreatic cancer are very strong for those under 60, and then get weaker for those 60 to 70, and then almost don't exist for those over 70. So in other words, pancreatic cancer seems to be more preventable at younger ages. When you get to older age groups, it gets less protective. So we went back and looked at physical activity by age. And we did see that in the younger age group, under 70, being inactive was associated with a 37% increased risk, but there was no benefit for older age. It's not to say that older people shouldn't be active, but for pancreatic cancer, most of the benefit will happen early in life. And then finally, for prostate cancer, remember I talked a little bit about a slight increased risk in total prostate cancer. However, we've seen that prostate cancer has the opposite. Remember, pancreas, its early life is important. For prostate, it's later life that's important, and it's vigorous activity at high levels and for advanced prostate cancer. So it's very specific. It's the associations can be different by cancer. So for prostate cancer, to get a benefit, it's mainly in older men, and it's only for vigorous activity, and it's for pretty high levels. There's not a linear dose response. So we don't know exactly why that is, but there may be something peculiar for prostate cancer. So just to summarize, maximal benefit and overall cancer would occur for maintaining physical activity over the life course, but for specific cancers, there could be periods of special importance. So for colon, it may be early, midlife for pancreatic, and late life for prostate cancer. And so just to finish up quickly here, I didn't say much about weight training and cancer prevention. There's very little data. There's a lot of epidemiologic data on aerobic exercise. In the health professionals, surprisingly, for colon cancer, there was an increased risk, but just p-value 0.05 for resistance training, which is a little bit worrisome. And then for bladder cancer, there was a protective association, and for kidney cancer, a suggestive protective association. Now, really, there's only one other study, epidemiologic study. It's called the NIH-ARP, which looked at resistance training in this detail. And it's interesting, for colon cancer, they got the opposite. So it's 0.78, and it was a p-value 0.05. So I think these are just chance findings. So it actually was reassuring for us that another study got almost the opposite. If you combine them, you probably get no association, but that's better than a positive association. For bladder cancer, we had seen a protective association, and they had seen nothing. So maybe our initial finding was chance. And for kidney cancer, it was the only cancer where both studies suggested an association, a protective. So there's a lot less data for resistance training, but at least there's some suggestion for kidney cancer. And I think I need to be closing up here. So these are my conclusions. So leisure time aerobic physical activity is associated with lower risk of 12 cancer types, and associations are particularly strong for digestive system cancer. Now, both vigorous and moderate physical activity are effective. And so recommendations of 150 to 300 minutes per week of moderate, or 75 to 150 minutes per week of vigorous, will lower risk. So the current recommendations lower risk, but I think maximal benefits may occur at even higher levels. Now, the maximal benefits accrue over maintaining physical activity over the life course, but it's never too late to start. You'll get some benefit even if you start late in life. The primary benefits are associated with reductions in visceral and hepatic adiposity and things like inflammation and hyperinsulinemia. And the benefit can accrue even with modest weight reductions. You don't have to lose a lot of body weight to get the benefit. And on weight training, the evidence is limited, and there's some suggestion for a benefit on kidney cancer, but more work needs to be done for weight training. So thank you, and I'd be happy to take questions at this point.